this week on the BackTable podcast.
Well, I think that it's really important to recognize that the ablation and all these procedures should be discussed as a multidisciplinary approach. And if you are an interventional radiologist or interventional pain working out in the community, it's always good to have a neurosurgeon on your side there just to run it through with them, whether in a formal multidisciplinary approach or not.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com.
This is Michael Barraza, returning as your host, recording from Baton Rouge, Louisiana. Today, we're going to talk about spinal ablation from the perspective of a neurosurgeon, and I'm honored to be joined by Dr. Tran from the Moffitt Cancer Center. Dr. Tran, thanks for joining us.
Oh, thanks for having me.
So you off this weekend?
Yes, I was on call last weekend, so this weekend's a weekend off.
I had last night, but I'm glad to be off for the rest of the weekend. I want to hear a little bit about your practice. We had somebody else from the Moffitt Cancer Center last week, Dr. Ninesh Parikh, talking about something completely different. Last week, we were talking about, ablation for kidney masses. Today, we're talking about spine. Is spine a large part of your practice?
Yeah, spine is about 80% of my practice here at Moffitt.
Primarily for cancer, or do you do, fusions and that kind of stuff too?
My practice will, it invariably, I treat all cancer patients. So if we do have cancer patients that come in and that they may have some degenerative disc disease, then I'll operate on that. But I would say that the vast majority of the practice is spinal cancer related.
I would imagine in an institution like Moffitt, you're pretty busy.
Yeah, it's quite a busy practice.
Do you guys, is it a training program? Do you have residents and fellows?
We have residents from University of South Florida that who rotate through with us, but we also have 2 dedicated neurosurgical oncology fellows every year.
How long is that fellowship program?
The fellowship program is for 1 year for each of them. And so it's, and it encompasses the full spectrum from both brain oncology to spine oncology.
So focus it back on spine. I treat a fair number of spine patients, but certainly not the full breadth of spine therapies that you offer. And I'm kind of curious, where this fits into your practice. Could you tell me first about what, some of the open options are for treating patients with spine metastases or even primary spine tumors?
Yeah, I think that I've noticed in my career that the practice has really changed quite a bit within the past 10 years. While I was in neurosurgical training, the traditional standards has always been, if you have cancer metastasized to the spine, it comes down to surgical decompression and probably a pedicle screw fusions fixation just to stabilize the spine. Always very large, very invasive practices. And within the past 10 years, I've noticed that vertebral augmentation and now ablation, it's encompassed more of the minimally invasive procedures, and that to patients who were not candidates for, the traditional, more invasive surgeries in the past are now candidates. And what that's allowed us to do is that it's allowed them to have better quality of life and allow them to actually go on to other systemic therapies.
Yeah, I would imagine most of these are for palliative treatment.
Yes.
One other question I had is, because of your background as a neurosurgeon doing both open and less invasive treatments, I would imagine in terms of ablations, you're probably able to be a bit more aggressive and treat some of the more challenging lesions that non-operative interventionists like myself can't normally do. Is that true?
I think that's a big plus of having the surgical background.
Yeah.
And that patients who come in who have lesions that are kind of questionable, I'm able to offer them the less invasive procedures like ablation or kyphoplasties first. And if they fail that, then I have the option of proceeding ahead with the more traditional spinal surgeries.
Do you ever do any kind of like hybrid approach procedures? Let's say like for cervical spine lesion, just kind of, do an exposure and then ablation, or is it usually one or the other?
No, I think that that's a great question. I think that my practice now has moved very much to a hybrid procedure.
That's cool.
Just as an example, in the past, if somebody who has metastatic disease, maybe some epidural extension, you think that you would have to do a complete decompression with a laminectomy and then a fusion. Now I can just go in and just do an ablation and maybe plus or minus kyphoplasty on top of that, and then just do pedicle screw fixation and through a minimally invasive approach. And so what takes a 4 or 5 day hospital stay, prolonged recovery, down to outpatient procedure or just an overnight stay only.
It's awesome. So just from my knowledge, when you're debating doing just ablation versus ablation versus pedicle screw or not, which ones are going to need the pedicle screws after?
We traditionally think about that as either a 2-column or 3-column.
Sure.
I think the spine is that. So patients who have primarily anterior column disease, those are very good candidates for just the ablation and augmentation. Whereas if they have the posterior column involving the facets or the spinous processes, then they do require pedicle screw fixation.
And so, as you kind of progressed more toward the minimally invasive option, what have you noticed in terms of outcomes?
Well, I think that in the short-term outcome, I've noticed that patients get pain relief much faster than they would with traditional surgeries. And I think that's, the data is still coming out as ablation is a fairly new procedure out there. But I think that anecdotally, it's noticed within our institution that radiation oncologists, medical oncologists will often refer patients for these minimally invasive procedures before going on to radiation or chemotherapy, and because they know that it improves the quality of life and allows those patients to go through the other procedures with much better quality of life and less pain.
Yeah, that's something we've talked about on here before. We had a radiation oncologist come on and talk with us about it. And it seemed like the consensus was that doing this prior to radiation therapy was better than the alternative, doing radiation therapy first, followed by this. Is that your experience as well?
Yes, that's absolutely is my experience. And, having been in practice, for over 10 years now, I saw when I came into practice, really that's when the CAFE study first came out, and that's cancer related to spinal metastases. And that CAFE study really looked at whether or not vertebral augmentation, the kyphoplasty procedures, were effective for that. And so prior to that, it wasn't really embraced. And then after that, it became embraced. And so the practice changed where the radiation oncologist would send patients to us for treatment first before they proceed on with radiation. And now, with the ablation coming into play, I think we're getting a greater referral for that kind of the neoadjuvant therapy, I think.
Yeah, absolutely. So looking at these, I'm curious, to get your perspective in terms of lesion selection, like, which lesions are going to be good candidates for ablation versus, either a decompression or either operative or non-operative management that doesn't include ablation.
Well, patients who have disease that may extend in the epidural space, that may have some neural compression, those are, I think they definitely need to be evaluated by a neurosurgeon to determine whether or not decompression is required. But patients who have isolated disease to the anterior column, I think those are excellent candidates.
How do you approach lesions? And I see these a lot where, it'll be kind of in the anterior medial aspect of the vertebral body, but there is a decent sized extraspinal component.
Well, those, in terms of treatment for the spinal lesions, I feel that strongly that it always has to be a multidisciplinary approach. And that none of us really practice in a vacuum. And so when they come, my focus may be on the tumor within the spine itself, but then it incorporates a follow-up with a radiation oncologist or a medical oncologist to discuss chemo and radiation.
Okay. So I'm curious, are you the only person in your hospital who is doing these?
No, we have 5 surgeons altogether, but there are 3 of us. 3 out of the 5 do spinal oncology.
In terms of ablations, do any other practitioners in the hospital do them? Do any interventional radiologist or anesthesiologist or anyone else? Or are they all done by neurosurgery?
No, it's we have interventional radiology and as well as interventional pain.
Okay.
So all 3 disciplines will do ablations.
So how do these patients get evaluated? Is there a tumor board or something where these patients get discussed?
Yeah, typically, they end up going through multiple tumor boards. And so Moffitt is set up so that it's a kind of a systems based. And so if you have lung cancer, you're part of the thoracic program. If you have renal cancer, you're part of the GU program.
Okay.
But they have their own tumor board. And then they refer, based on that decision making, they refer to neurosurgery. And we have our own tumor board. And that does incorporate all the spine surgeons, the radiation oncologists, and oftentimes some of the neuro-oncologists. And then we make the decision to proceed ahead with the appropriate treatments.
One question that I forgot to ask you is how you learned to do this. So did you do these in training?
No. Well, I did some of the kyphoplasties in training.
Sure.
And so I think you just have to keep in mind that, the CAFE study came out in 2010. And so prior to that, the kyphoplasty was not as popular of a procedure. It was only occasionally performed. And so after that study came out, then people started embracing the more minimally invasive procedures. So that's with the kyphoplasty, the augmentation. And then ablation has only been around for spine, has only been probably around for about the last 5 or 6 years. And so all that was performed here in my practice. I picked it up on practice.
The next thing I have for you is, you're the only neurosurgeon involved with the Opus One trial that looked at spine ablations, which adds really some unique perspective already. Could you share any of I think that the last update that we had on the Opus One trial, basically what we have seen from spinal ablation, as we got farther out of these patients?
We had, I think when you had discussed this with Dr. Levy and Dr. Bagla in the past, I think that was the interim study. And since then, the final study data analysis came out for the Opus One, and really that concluded all the 1-year follow-up on these patients, and it concluded that all the improvements that we had in terms of quality of life and pain reduction was durable, starting from about 3 days and extended out to 12 months.
Aaron had talked to both Jason and Sonny before we had this discussion, and just to figure out the best way to go about doing this. And one of the things that they had shared was that you're really interested in the post-procedure imaging of these patients. Is that true?
Yes. And that's the benefit of working at a cancer center. I'm looking at this not just from the pain control, but I'm also looking at this as an oncologist, as a tumor control. And ablation for the spine, at least, it's FDA indicated for treatment of painful cancer-related pain.
Yeah.
But if you look at it in the broad perspective, I think we know that pain is caused by more than just fractures. Cancers can stretch the periosteum. They secrete a lot of cytokines. And so if you ablate the tumor, and so you destroy the tumor, well, then all those other factors are gone and you get pain control that way. And so indirectly, what you're doing is you're controlling the cancer. And so that's my interest in follow-up, is that we continue to follow these patients up every 3 months with serial imaging, whether that's a PET scan or MRIs or CT scans. And we see that patients who have been treated with ablation, there's decreasing enhancement, there's a decreased uptake on PET scan. So it all shows that we do get pain control, and we do see that there's a reduction in tumor burden at the treated levels.
That's really interesting because, I'm used to looking at this from a palliative standpoint. But again, as you said, looking at it like an oncologist, that's different. I'm curious if you think that there is a potential down the road for, an isolated spine metastasis or even a small primary bone tumor. If this is a possible treatment option, or, for those patients, if you're proceeding as you normally would.
Yeah, I think this is really is a great option for that. And I think that, to really prove that point, I think we need to start looking at prospective studies, long-term studies looking at with a focus on tumor control.
Yeah, it might be interesting to look at some different MRI protocols, just look at it like we might look at a tumor somewhere else,
Exactly.
I mean, it makes sense. I mean, the last one of these I treated was actually a osteoid osteoma, had an outstanding response. I don't see any reason why it couldn't work for, another primary tumor.
Right. And ablations, have been used for even non-osseous tumors, right? It's been well documented for livers, for soft tissue.
It's like a huge part of my practice.
Yeah. So I don't see why it can't be applied to the spine. Just the challenge has always been traditionally that the spine is a very complex structure, complex anatomy. And so getting access to it has been a challenge, but, having been able to overcome that, I think we should treat it like any other soft tissue.
Well, so that's where I think, that, your options as a neurosurgeon, I'm limited to percutaneous probe placement, your abilities as a neurosurgeon. I'm curious how you would approach it, these larger tumors that, I'm just treating part of it. I mean, do you try to treat the entire lesion for some of these bigger ones?
I think that the lesson I learned is early on, I would try to treat just even if it's a small lesion within the spine, I'll try to just ablate the smaller lesion. And I found that patients may do well for short term, but then they may have recurrence of disease within that vertebrae later on. And so now I will try to treat the entire vertebrae whenever they see them. So for large lesions, I try to ablate the entire lesion. Even for small lesions, I'll try to ablate the entire vertebrae.
And so I would imagine this is probably somewhere you're looking at some of these hybrid techniques where you're, part open and part percutaneous. Or how many probes are you placing at a time?
Typically just only 2 probes. We use 2 probes at a time, or we may have to reposition the probes to different locations.
And how are you evaluating the coverage of the tumor?
Medtronic has a nice program that helps us calculate the volume that we're ablating. based on the length of the probe. And so just based on that, I kind of divide up the tumor into different multiple quadrants or multiple zones. And that's how I decided on how many zones to ablate.
Well, Dr. Tran, what else am I forgetting to ask? What do you think is important to touch on that I'm missing?
Well, I think that it's really important to recognize that the ablation and all these procedures are really should be discussed as a multidisciplinary approach. And if you are an interventional radiologist or interventional pain working out in the community, it's always good to have a neurosurgeon on your side there just to run it through with them, whether in a formal multidisciplinary approach or not, and run it through and discuss the case that way. I work with the interventional radiologist and interventional pain in my practice at Moffitt, but I also collaborate with many in the community. And so they run cases by me. We discuss it as if we're having our own tumor board. We discuss about how to approach it, and that I'm there. I now know the patient, and I'm there as backup in case they are unsuccessful, or if they're not able to achieve pain, well, then they can proceed on with me. But I think it's a very much of a collaborative approach.
I think that's a really good point. I don't think a lot of us out there have that. And, I think that's something we could all look to seek.
Yeah. And I think that's something that should be welcomed. I don't see myself as, competing with my interventional radiologist or interventional pain. I think we're all collaborating. We all have a single goal of taking care of these cancer patients. In fact, in part of my training program here, I have the interventional pain fellows will rotate through with me as well.
No kidding.
And so they get my perspective.
Yeah, man, that's awesome. Well, thank you for sharing your time and your expertise with us today. This is really valuable for all of us out there. We don't get to hear from the neurosurgeon much. Thank you, and thanks to all of our listeners for joining us.
So thank you for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Jinwei Kennebrew.
Thanks again, and see you next time.